What is an inguinal hernia? An inguinal hernia is a protrusion of abdominal contents through the inguinal canal. There are two types: indirect and direct. An indirect inguinal hernia protrudes through the internal inguinal ring, while a direct inguinal hernia protrudes through the posterior wall of the inguinal canal. How does an indirect inguinal hernia develop? An indirect inguinal hernia occurs when abdominal contents, such as bowel, protrude through the internal inguinal ring, into the inguinal canal. This occurs due to failure of obliteration of the processus vaginalis after birth, leaving a potential space for abdominal contents to protrude through. What are the signs and symptoms of an inguinal hernia? Symptoms may include a bulge or swelling in the groin, pain or discomfort in the groin, a sense of heaviness or dragging in the groin, pain with straining or coughing, and discomfort when bending over. The bulge may increase in size when standing or straining and often subsides when lying down. How is an inguinal hernia diagnosed? Diagnosis is made based on medical history and physical examination. The provider will visually inspect and palpate the inguinal region for bulges or swelling. Diagnostic tests are not usually necessary, but may include ultrasound or CT scan to further evaluate the hernia. How are inguinal hernias treated? Most inguinal hernias are treated surgically with herniorrhaphy to repair the weakened abdominal wall. This may be done with open surgery or laparoscopically depending on the type and size of the hernia. Non-surgical options include wearing a truss or hernia belt to provide support. What are the potential complications of an untreated inguinal hernia? Potential complications if left untreated include incarceration, which is when the contents become stuck in the abdominal wall, or strangulation, which compromises blood supply. This can lead to tissue death or bowel obstruction. Other risks include chronic pain and discomfort. What factors increase the risk for developing an inguinal hernia? Risk factors include being male, family history, chronic cough or constipation, pregnancy, rapid weight loss, ascites, peritoneal dialysis, abdominal surgery, smoking, advanced age, and strenuous physical activity. What is the difference between a direct and indirect inguinal hernia? An indirect inguinal hernia protrudes through the internal inguinal ring lateral to the inferior epigastric vessels. A direct inguinal hernia protrudes through the posterior wall of the inguinal canal medial to the inferior epigastric vessels. How does a direct inguinal hernia develop? A direct inguinal hernia occurs due to a weakness or defect in the transversalis fascia of the posterior wall, allowing abdominal contents to push directly through the weakened area. Risk factors include prior abdominal surgery, aging, collagen disorders, and increased intra-abdominal pressure. When repairing an inguinal hernia, why is the use of mesh preferred over primary suture repair? Primary suture repair has a much higher recurrence rate compared to mesh repair. The mesh provides additional strength and support to the abdominal wall that primary closure alone cannot provide. The mesh helps reduce tension on the repair and provides scaffolding for tissue and growth. What postoperative complications can occur after inguinal hernia repair? Potential postoperative complications include hematoma, seroma, surgical site infection, mesh infection, urinary retention, chronic pain or neuropathy, and hernia recurrence. Most complications are minor, but prompt evaluation is recommended for any concerns. How does a physician distinguish between an indirect and direct inguinal hernia on physical exam? The examiner invaginates the scrotal skin with the finger and asks the patient to cough or bear down. An indirect hernia will protrude laterally to the inferior epigastric vessels while a direct hernia will protrude medially. What maneuvers are used to reduce an incarcerated inguinal hernia? Gentle manual pressure should be applied around the hernia contents directed away from the scrotum and towards the abdomen. The patient may be placed in Trendelenburg position to use gravity to assist reduction. If this fails, procedural sedation can be used to achieve muscle relaxation. What are the indications for emergent surgical repair of an inguinal hernia? Emergent surgery is indicated if the hernia is irreducible or if there are signs of strangulation such as severe pain, tenderness, fever, leukocytosis, tachycardia, peritonitis or bowel obstruction. Strangulated hernias can lead to bowel ischemia, perforation and sepsis. What type of anesthesia is typically used for elective inguinal hernia repair? Most elective repairs can be done under local anesthesia with sedation or a spinal anesthetic. General anesthesia is also an option but is usually reserved for complicated or emergent cases. What advice is given to patients post-inguinal hernia repair? Patients are advised to avoid heavy lifting or straining for 4-6 weeks after surgery. Use pain medication as needed, keep the incision clean and dry, and watch for signs of infection. Follow up with surgeon as recommended and discuss when normal activities can be resumed. What is the recurrence rate for inguinal hernia repair with mesh versus primary repair? Recurrence rates are lower with mesh repair compared to primary suture repair. With primary repair, recurrence rates can be up to 15%, while with mesh the recurrence rate is less than 5%. How can a femoral hernia be differentiated from an inguinal hernia? A femoral hernia protrudes through the femoral canal medial to the femoral vein. It is below the inguinal ligament, while an inguinal hernia protrudes through the abdominal wall superolateral to the pubic tubercle and above the inguinal ligament. What are the differences between Liechtenstein and laparoscopic inguinal hernia repair techniques? The Liechtenstein repair is an open procedure using mesh through an incision in the inguinal region. Laparoscopic repair is minimally invasive using small incisions and mesh placement intra-abdominally under direct visualization. What postoperative instructions should be given for laparoscopic inguinal hernia repair? Avoid heavy lifting for 2-4 weeks. Refrain from straining with bowel movements. Restrict strenuous activity for 2 weeks. Use pain medication as needed. Watch for signs of infection, hematoma or seroma. Follow up with surgeon in 1-2 weeks. When is watchful waiting appropriate for an inguinal hernia? Watchful waiting may be appropriate for minimally symptomatic or asymptomatic hernias in patients who are high-risk surgical candidates. Elective repair is still preferred for most patients to prevent complications. What is the processus vaginalis and why is it relevant to inguinal hernias? The processus vaginalis is an embryologic outpouching of peritoneum that precedes the testis during fetal development. Failure of obliteration after descent of the testis leaves a potential space for abdominal contents to protrude, resulting in an indirect inguinal hernia. How does a sports hernia differ from an inguinal hernia? A sports hernia involves weakening or tears in the transversalis fascia without protrusion of abdominal contents. There may be bulging and pain due to muscle imbalance but no palpable mass. Imaging is often required for diagnosis. What are the main differences in pediatric versus adult inguinal hernias? Pediatric hernias are more likely to be indirect due to patent processus vaginalis. Repair involves high ligation of processus. Adults are more likely to have direct hernias due to muscle weakness. Mesh repair is preferred to prevent recurrences. What rare types of abdominal wall hernias should be on the differential for inguinal hernias? Less common hernias to consider include obturator, femoral, lumbar, and Spigelian hernias. Thorough physical exam and imaging helps distinguish between types. When is elective repair indicated for an asymptomatic inguinal hernia? Elective repair is generally recommended even for asymptomatic inguinal hernias to prevent risk of incarceration or strangulation. Exceptions may include minimally symptomatic hernias in high-risk patients unfit for surgery. What is the role of preoperative imaging for diagnosis of an inguinal hernia? Imaging is not routinely indicated if diagnosis is apparent clinically. Ultrasound or CT may be considered for unclear cases to confirm the diagnosis and provide details about the extent, contents, and potential complications. How should anticoagulation or antiplatelet medications be managed perioperatively? Stopping anticoagulants raises thrombosis risk while continuing raises bleeding risk. Bridging therapy is individualized balancing risks. Antiplatelets like aspirin are often continued perioperatively. What are recommendations for resuming activity after inguinal hernia repair? No heavy lifting 20 pounds for 2-4 weeks. No straining with bowel movements. Avoid strenuous exercise for 2 weeks. Driving restricted for 1 week usually. Increase activity gradually after follow-up. What signs or symptoms after hernia repair warrant prompt surgical re-exploration? Severe or worsening pain, fever, drainage, excessive swelling, discoloration, abdominal rigidity or rebound tenderness may indicate complications like bleeding, infection or bowel injury. How can recurrence risk be minimized when repairing an inguinal hernia? Use mesh reinforcement, ensure adequate mesh overlap of defect, minimize tension on repair, identify and repair all potential defects, follow recommended activity restrictions postoperatively. What anesthesia risks should be discussed before repair? Bleeding, infection, nerve injury, urinary retention, pulmonary issues, cardiovascular events, nausea or vomiting, chronic pain or neuropathy, reaction to anesthesia medications. Risks are low but should be discussed. What is the role of antibiotic prophylaxis in inguinal hernia repair? Routine antibiotics are generally not recommended, except in cases with increased risk factors for infection such as immunosuppression, prosthetic implants, or significant contamination. How soon after inguinal hernia repair can patients expect to return to work? Most patients can return to clerical desk work within 1 week as long as they avoid heavy lifting or straining. Patients in physically demanding jobs may require 2-4 weeks off work. What signs or symptoms after hernia repair should prompt evaluation for chronic groin pain? Unresolving pain lasting 6 months, allodynia, hyperalgesia, numbness, shooting burning pain, especially if impacting quality of life or activities, may indicate nerve entrapment or chronic pain syndrome. What advice should be given about driving after open inguinal hernia repair? Patients should avoid driving for at least 1 week after surgery, and longer if taking narcotic pain medications. They should demonstrate full active range of motion before driving. Which patients are candidates for watchful waiting rather than surgical repair? Elderly or debilitated patients with asymptomatic or minimally symptomatic hernias who are high risk for surgery may opt for watchful waiting if they can be monitored closely. What are the advantages of laparoscopic inguinal hernia repair? Faster recovery, less postoperative pain, lower risk of wound infection, able to repair bilateral hernias, better visualization of anatomy. What is the Schuldeis hernia repair technique? The Schuldeis repair is an open, tension-based surgical technique using sutures without mesh to reconstruct the inguinal floor using 4-layered interrupted sutures. How soon after laparoscopic inguinal hernia repair can patients typically return to work? Most patients can return to sedentary work within 3-5 days after laparoscopic repair. Patients with physically demanding jobs may require up to 2 weeks off work. What are the potential risks of using mesh for inguinal hernia repairs? Risks include infection, adhesion, fistula formation, mesh migration, chronic pain, mesh rejection or extrusion, orchitis, and testicular atrophy. Proper surgical technique can minimize these risks. What is the role of prophylactic antibiotics prior to repair of recurrent inguinal hernias? Because recurrence may be associated with increased mesh infection risk, the latest guidelines recommend antibiotics for recurrent repairs even without specific risk factors. Why are elderly patients at higher risk for complications with inguinal hernias? They have decreased collagen tissue strength, comorbidities, potential anticoagulation, and are at risk for incarceration or strangulation due to looser connective tissue. How can postoperative urinary retention be minimized after hernia repair? Limiting perioperative fluids, using regional anesthesia, avoiding excessive opioids, and monitoring for retention with timed voids or bladder scans. What instructions should be given to patients after undergoing laparoscopic inguinal hernia repair? Avoid heavy lifting for 2 weeks, don't strain with bowel movements, restrict vigorous activity for 1 week, use pain medications as needed, keep incisions clean and dry, watch for signs of infection like fever or swelling, call surgeon with any concerns, follow-up appointment in 1-2 weeks. What are the indications for mesh removal following inguinal hernia repair? Mesh removal may be indicated for complications like chronic intractable pain, mesh infection, mesh erosion through skin, continued drainage from sinus tracts, or mesh migration or contraction causing severe pain or organ dysfunction. How does an inguinal hernia differ from a sports hernia? An inguinal hernia involves protrusion of tissue through a defect in the abdominal wall. A sports hernia is a tear or weakness of the transversalis fascia without a true herniation of tissue. What are the advantages of open inguinal hernia repair techniques compared to laparoscopic repair? Open repair allows better visualization in complex cases, easier manipulation of contents, lower risk of inadvertent organ injury, shorter operative times, and lower cost. What postoperative signs or symptoms warrant immediate evaluation after open inguinal hernia repair? Severe pain, swelling, redness, drainage, fevers, vomiting, abdominal distension or rigidity which could indicate a serious complication like bowel injury. What is the ideal size of mesh to use for inguinal hernia repair? Approximately 10 by 15 cm mesh is commonly used to allow for adequate overlap of the defect with at least 3-5 cm margin. Larger direct defects may require larger mesh. How can the risk of chronic groin pain be minimized after inguinal hernia repair? Careful handling of tissues, avoiding excessive electrocautery, fixing mesh away from nerves, using lightweight mesh, and preserving the ilioinguinal, iliohypogastric, and genital branch of genitofemoral nerves. What are the indications for antibiotics prior to elective inguinal hernia repair? Antibiotics are only recommended for patients with increased risk of surgical site infections such as immunosuppression, diabetes, smokers, those with COPD, or significant contamination. How long after open inguinal hernia repair until patients can resume driving? Patients should avoid driving for 1 week after open repair to allow for adequate healing and range of motion. Longer if taking narcotic pain medications. What is the usual length of hospital stay after routine laparoscopic inguinal hernia repair? Most patients can be discharged the same day. Some may stay 24 hours for observation. Hospitalization longer than 1 night is uncommon unless complications arise. What regimen is recommended for VTE prophylaxis after hernia repair? Low molecular weight heparin or mechanical prophylaxis like compression stockings is recommended for higher risk patients. Ambulating early is also key. What are some common long-term complications that can occur after inguinal hernia repair? Chronic groin pain, mesh infection or rejection, mesh erosion through skin, mesh migration, recurrence, testicular pain or atrophy, vascular injury, and neuralgia are potential long-term complications. How can hernia recurrence after primary open repair be prevented? Use of mesh reinforcement, adequate mesh overlap of defect edges, tension-free repair, identifying and closing all potential hernia sites, avoiding postoperative complications like hematoma or infection. What are the risks and benefits of using absorbable versus permanent mesh for inguinal hernia repairs? Absorbable mesh has lower infection risk but higher recurrence rate. Permanent mesh has lower recurrence rate but higher infection and fibrosis risk. Choice depends on defect size and patient factors. When is hernia repair indicated in asymptomatic pediatric inguinal hernias? Repair is recommended soon after diagnosis to prevent incarceration. Delay risks bowel obstruction, so elective repair is preferred regardless of symptoms. What postoperative signs or symptoms warrant immediate evaluation after laparoscopic inguinal hernia repair? Unrelenting shoulder pain, abdominal pain, distension, fever, tachycardia, hypotension or oliguria could indicate serious complications like organ injury. What should be included in patient education before undergoing an open inguinal hernia repair? Overview of procedure, expected recovery timeline, activity restrictions, wound care, signs of complications to monitor for, pain management, follow-up instructions. Encourage questions. How can postoperative urinary retention be prevented after open inguinal hernia repair? Limit perioperative fluids, use short-acting anesthesia, avoid excessive opioids, consider regional anesthesia, monitor for retention, encourage early ambulation. Consider prophylactic alpha blockers. What are recommendations for timing of hernia repair in pregnant patients? Repair is ideally done during second trimester before uterus enlarges significantly. Only emergent repair is strangulated. Elective repair is otherwise deferred until postpartum. When is hernia repair indicated for a reducible inguinal hernia with intermittent symptoms? Repair is still recommended even if reducible and intermittent symptoms, since there is still risk for incarceration or strangulation. Elective repair can prevent complications. What are the most important perioperative considerations for patients on anticoagulants undergoing inguinal hernia repair? Balance thrombosis risk if anticoagulants held versus bleeding risk if maintained. Bridge with heparin if high thrombosis risk. Use mechanical VTE prophylaxis. What are the risks and benefits of local anesthesia versus general anesthesia for inguinal hernia repair? Local less medication risks, shorter recovery. Risk of pain, incomplete numbness. General controlled setting, complete relaxation. Risks of airway compromise, postoperative nausea. How soon after inguinal hernia repair can patients expect to resume strenuous physical activity? Light activity can resume in 1-2 weeks, but strenuous activity should be avoided for 4-6 weeks to allow adequate healing and strength of repair. What are the indications for initial conservative management rather than repair of an inguinal hernia? Conservative management may be appropriate for asymptomatic or minimally symptomatic hernias in patients unfit for surgery due to comorbidities. These patients require close monitoring. How can hematoma formation be minimized following inguinal hernia repair? Careful hemostasis, drain placement if needed, avoiding anticoagulants if high bleeding risk, activity modification and compression post-operatively. What are the signs and symptoms concerning for recurrence after prior inguinal hernia repair? Bulge or swelling in groin, pain with straining or coughing, feeling of pressure, dragging sensation in groin, difficulty with urination or defecation. Physical exam confirms diagnosis. What factors predispose to hernia recurrence after prior mesh repair? Insufficient mesh overlap, mesh contraction, missed hernia sites, wound infection, hematoma formation, poor tissue incorporation, inadequate fixation. What patient factors increase the risks associated with elective inguinal hernia repair? Older age, obesity, smoking, diabetes, immunosuppression, chronic steroid use, anticoagulation, prior abdominal surgery, comorbidities like COPD. These factors raise risks for complications. How can surgical site infections be prevented after inguinal hernia repair? Antibiotics in high-risk cases, chlorhexidine skin prep, proper sterile technique, gentle tissue handling, reducing operating room traffic, proper wound care post-operatively. What are the indications for incisional hernia repair compared to watchful waiting? Repair is indicated for symptomatic hernias, incarceration, strangulation, obstructive symptoms, skin complications, or interference with activities. Watchful waiting may be reasonable for small, asymptomatic hernias. When should surgical consultation be obtained for an inguinal hernia? Surgical consultation should be obtained for new diagnoses, worsening or enlarging hernias, change in symptoms, incarceration, strangulation, or hernias in female patients due to higher risks. What factors are considered when selecting a laparoscopic versus open repair for inguinal hernias? Defect size or location, surgeon experience, patient habitus, history of abdominal surgery, potential for complications, costs, patient preference. Open preferred for complex cases. How can nerve injuries be avoided during open inguinal hernia repairs? Meticulous dissection, nerve identification, avoid excessive cautery, hydrodissection, mesh placement away from nerves, tacking fixation rather than sutures near nerves. What is the ideal postoperative follow-up schedule after an uncomplicated open inguinal hernia repair? Follow up at 1-2 weeks to assess wound healing, review activity guidelines, address any new or persistent symptoms. Then follow up again in 4-6 weeks to confirm recovery and release to full activity. Annual exam. When is CT imaging indicated in the diagnosis of an inguinal hernia? CT is not routinely used unless the diagnosis is uncertain clinically. CT can help distinguish inguinal from other types of hernias and evaluate for any complications if symptoms are concerning. How does an indirect inguinal hernia differ from a direct inguinal hernia? An indirect hernia protrudes through the internal inguinal ring lateral to the inferior epigastric vessels. A direct hernia protrudes through the posterior wall of the inguinal canal, medial to the epigastric vessels. What are the potential complications associated with non-operative management of inguinal hernias? The risks of incarceration and strangulation necessitating emergency surgery. Bowel obstruction, ischemia or perforation. Chronic pain and limitations. Skin changes and ulceration. When can hernia repair be considered for emergency versus elective surgery? Emergency repair is required for incarceration, strangulation, or obstruction. Otherwise, prompt elective repair is recommended even if reducible or minimally symptomatic. What are the most serious potential complications of inguinal hernia repair? Hematoma, infection, chronic pain, recurrence, testicular ischemia, bladder or bowel injury, vascular injury, anesthesia complications, death in extremely rare cases. What is the preferred antibiotic prophylaxis for patients undergoing mesh inguinal hernia repair? First-generation cephalosporin cefazolin is the typical recommended prophylactic antibiotic. Clindamycin or vancomycin may be alternatives for penicillin-allergic patients. When is scrotal ultrasound indicated for evaluation of an inguinal hernia? Ultrasound is helpful to evaluate involvement of the spermatic cord, differentiate direct versus indirect hernia, assess for testicular complications, and identify occult hernias not apparent on exam. How does formation of an Ammian's hernia differ from typical inguinal hernias? An Ammian's hernia contains the vermiform appendix within the hernia sac. It accounts for about 1% of inguinal hernias and often presents with right lower quadrant pain. What advice should be given to patients about driving restrictions after laparoscopic inguinal hernia repair? Patients should avoid driving for 5-7 days after laparoscopic repair. They should wean off narcotic pain medication and demonstrate full mobility before driving. When are mesh plugs utilized compared to flat mesh panels for open inguinal hernia repairs? Plugs are often used for small indirect hernias while flat mesh is preferred for direct defects or larger hernias requiring more reinforcement. What is the recommended follow-up after incarcerated inguinal hernia reduction? Patients should be observed for 12-24 hours after successful reduction to monitor for recurrence or complications like bowel ischemia. Elective repair should be scheduled soon after discharge. How does cough impulse testing help diagnose an occult inguinal hernia? The examiner invaginates scrotal skin over the inguinal canal while the patient coughs. A palpable impulse indicates an occult direct hernia. What are the risks and benefits of local anesthesia versus general anesthesia for inguinal hernia repairs? Local anesthesia has less medication risks but may be uncomfortable. General anesthesia provides comfort but has more medication risks like nausea and urinary retention. When can patients expect to return to work after laparoscopic inguinal hernia repair? Most patients can return to sedentary jobs within 3-5 days, while those with physical jobs may require 7-14 days recovery before returning to work. How should anticoagulation be managed perioperatively for a patient undergoing urgent inguinal hernia repair? Hold anticoagulants if safe and use mechanical prophylaxis. Resume anticoagulation soon after surgery when hemostasis assured. Bridge if high risk. What are the most important postoperative instructions for patients after inguinal hernia repair? Restrict heavy lifting or strenuous activity. Avoid straining at stool. Follow wound care instructions. Watch for signs of infection. Take pain meds as needed. Contact surgeon with any concerns. What are some tips to minimize postoperative pain after open inguinal hernia repair? Local anesthetic infusion catheters, local anesthetic impregnated mesh, field blocks. Avoid mesh fixation near nerves, gabapentinoids or non-steroidal, ice therapy, proper activity modification. When is hernia repair indicated for asymptomatic pediatric inguinal hernias? Repair is recommended even if asymptomatic in children due to high incarceration risk. Surgery soon after diagnosis prevents complications. What are the indications for mesh removal following inguinal hernia repair? Intractable pain, infection, erosion through skin, persistent drainage from sinus tracts, severe pain or urinary symptoms from mesh migration or contraction. How long after mesh inguinal hernia repair until patients can resume heavy lifting? Heavy lifting should be restricted for at least 4-6 weeks after mesh repair to allow adequate scarring and strength of repair before significant strain. What are the risks and benefits of open preperitoneal hernia repair versus totally extraperitoneal TEP laparoscopic repair? Open has lower recurrence rate but larger incision. Laparoscopic TEP has faster recovery but higher recurrence risk and is technically challenging. When should hernia repair be delayed in trauma patients with inguinal hernias? Repair should be delayed if the hernia was pre-existing. In true acute traumatic hernias, prompt surgical repair is warranted once stabilized. What are the indications for elective repair of an asymptomatic inguinal hernia? Even asymptomatic hernias warrant elective repair to prevent the risks of potential incarceration or strangulation and avoid emergent surgery. Exceptions may be made in elderly or high-risk patients. How does an occult hernia differ from a typical palpable inguinal hernia? An occult hernia has no obvious bulging or palpable defect on exam when standing. Diagnosis requires techniques like Valsalva or cough impulse test to elicit swelling indicating a hernia. What type of hernia is most likely to present with bowel obstruction? Femoral hernias have the highest risk of incarceration and bowel obstruction compared to inguinal hernias. Therefore, any hernia with obstructive symptoms warrants prompt evaluation. How long after open inguinal hernia repair until driving is permitted? Most experts recommend avoiding driving for 1 week after open repair to allow for recovery and avoid straining the repair with automotive pedal use. When is hernia repair indicated for a patient with a chronic, stable inguinal hernia? Stable, chronic hernias still warrant elective repair to prevent future complications like strangulation and avoid the risks of emergent surgery. What are the most important factors when selecting a surgical approach for inguinal hernia repair? Defect characteristics, surgeon experience and preference, patient factors and medical history, potential risks, and patient choice after discussing. What are some common pitfalls leading to chronic growing pain after inguinal hernia repair? Poor dissection technique, excessive cautery use, improper mesh fixation, mesh folds or wrinkling, missed nerves, development of neuromas. Meticulous surgical technique is key. When should hernia repair be considered for an elderly patient with comorbidities? A. Even in elderly patients, repair is eventually warranted due to risks of emergent incarceration and strangulation. Operative risks versus benefits must be weighed. What are some tips to identify the ilioinguinal, iliohypogastric, and genital branch of genitofemoral nerves during open hernia repair? Look lateral to the spermatic cord structures near the internal ring. Use minimal blunt dissection. Perforate the transversalis with fingertip. Nerve blocks help confirm. What criteria are considered for determining medical necessity of elective hernia repair? Presence of a hernia on exam, symptoms such as pain or discomfort, interference with activities, employment requirements, risk of incarceration. How can urinary retention be minimized following an open inguinal hernia repair? Limit perioperative fluids, use short-acting anesthesia, avoid narcotics, use local anesthesia, monitor for retention, encourage early ambulation. Consider alpha blockers. When is scrotal swelling concerning after inguinal hernia repair? If asymmetric, rapidly enlarging, tense or firm swelling, could indicate concerning complications like hematoma, seroma, or abscess. Warrants prompt evaluation. What are some tips for reducing postoperative pain after laparoscopic inguinal hernia repair? Local anesthetic injection at port sites, intraperitoneal local anesthetic, reduce trocar size, adequate pneumoperitoneum, fix mesh away from nerves, gabapentinoids. When should hernia repair be delayed in a patient with significant comorbidities? Repair may be delayed in patients at high surgical risk until comorbidities are optimized, unless the hernia is symptomatic or complications arise needing urgent repair. What are some common errors leading to litigation related to inguinal hernia repairs? Nerve injuries, postoperative complications, recurrence leading to loss of work, lack of informed consent regarding potential risks and benefits. What are the indications for mesh removal after prior inguinal hernia repair? Intractable pain, erosion into organs, infection, draining sinus tracts, severe pain or obstruction from mesh contracture or migration. How does an incarcerated inguinal hernia differ from a strangulated hernia? Incarceration refers to irreducibility. Strangulation causes vascular compromise, often indicated by pain, fever, tachycardia, peritoneal signs concerning for bowel ischemia. When should hernia repair be delayed in the setting of acute illness? Acute infection or illness increases operative risks. Repair should be postponed until the acute process resolves, unless emergent indications like strangulation. What instructions are important to review with patients before discharge after inguinal hernia repair? Activity restrictions, signs of complications to monitor for, expected pain and recovery timeline, wound care, medication instructions, follow-up appointment importance. When should hernia repair be delayed in a patient with recent ME or unstable cardiac disease? Elective repair should be postponed at least 3-6 months after ME or cardiac intervention to allow for recovery and confer lower procedural risks. What factors predict increased risk for hernia recurrence after prior repair? Infection, hematoma, improper mesh placement or sizing, missed hernia sites, inadequate mesh overlap, excessive mesh tension, poor tissue incorporation. What are the risks and benefits of open preperitoneal hernia repair versus laparoscopic totally extraperitoneal TEP repair? Open preperitoneal has lower recurrence rate but larger incision. TEP has faster recovery but higher recurrence risk and steep learning curve. How does an irreducible inguinal hernia differ from an incarcerated hernia? Irreducible means it cannot be manually reduced into the abdomen but no vascular compromise. Incarcerated means contents are trapped with potential vascular obstruction. What are some common pitfalls leading to chronic neuropathic groin pain after hernia repair? Poor identification or protection of ilioinguinal, iliohypogastric, genital branch of genitofemoral nerves. Excessive cautery use. Improper mesh fixation near nerves. Neuroma formation. What is the usual recovery time until returning to work after an uncomplicated open inguinal hernia repair? For sedentary jobs, patients can usually return to work in 1-2 weeks. Physically demanding jobs may require 3-4 weeks before returning to full duties. How can urinary retention be minimized after laparoscopic inguinal hernia repair? Limit fluid intake perioperatively, use short-acting anesthesia, avoid narcotics if possible, use local anesthesia, monitor for retention, encourage early ambulation. What are the risks and benefits of anterior mesh placement versus posterior placement in open inguinal hernia repair? Anterior placement has lower recurrence rate but higher postoperative pain. Posterior placement has less pain but higher recurrence risk if mesh overlap is inadequate. When should hernia repair be expedited in an asymptomatic patient? Prophylactic repair may be expedited in those with occupations prone to hernia complications like pilots, construction workers, or athletes. What findings on examination could indicate strangulation of an incarcerated inguinal hernia? Severe pain, tenderness, fever, tachycardia, peritoneal signs, elevated WBC count, vomiting, lack of bowel sounds. How can the risk of chronic groin pain be reduced following laparoscopic inguinal hernia repair? Meticulous dissection, minimally invasive fixation, avoid excessive cautery, position mesh away from nerves, use lightweight, macroporous mesh. What are some tips to reduce postoperative urinary retention after laparoscopic inguinal hernia repair? Limit fluid intake perioperatively, use short-acting anesthesia, avoid narcotics if possible, use local anesthesia, monitor or encourage early voiding, consider prophylactic alpha blockers. How does an incisional hernia differ from an inguinal hernia? An incisional hernia occurs through a defect in a prior surgical scar. An inguinal hernia protrudes through the abdominal wall in the groin region. When is hernia repair indicated for a patient with cirrhosis and ascites? Repair should be deferred until ascites is controlled to lower recurrence risk after surgery. Maximizing liver function also optimizes surgical outcomes. What are some common causes of litigation related to complications from inguinal hernia repairs? Nerve injuries, urinary complications, chronic pain, recurrence, postoperative infections, inappropriate mesh use, inadequate informed consent, bowel injuries. How can the risk of chronic groin pain be reduced following open inguinal hernia repair? Meticulous tissue handling, nerve identification or preservation, lightweight mesh, avoid fixation near nerves, minimize electrocautery, proper activity modification. What are the current guidelines regarding antibiotic prophylaxis for elective inguinal hernia repair? Routine antibiotics are not recommended unless high-risk conditions like immunosuppression, prosthetics, or significant contamination are present. When is scrotal ultrasound indicated prior to inguinal hernia repair? For large or complex hernias, to evaluate involvement of spermatic cord structures, differentiate direct versus indirect hernia, identify occult hernias, assess testicular blood flow. What are some common complications that can occur after open inguinal hernia repair? Bleeding, infection, chronic groin pain, recurrence, orchitis, urinary retention, nerve or vascular or bladder or bowel injury, hydrocele, hematoma, seroma. How does a femoral hernia differ from an inguinal hernia? A femoral hernia protrudes through the femoral canal medial to the femoral vein, inferior to the inguinal ligament. An inguinal hernia protrudes superolateral to the pubic tubercle. When should antibiotic prophylaxis be given for elective inguinal hernia repair? Antibiotics are only recommended for high-risk patients like diabetes, immunosuppression, COPD, steroids, contaminated cases, or using prosthetic mesh. What are the most serious potential complications of laparoscopic inguinal hernia repair? Hernia recurrence, visceral injury, vascular injury, testicular infarction, mesh infection, chronic pain, pneumoperitoneum-related complication.